one of the features of the annual meetings of the Cardiovascular Research Center is the Michael Davis Memorial Lecture. For those of you who were not lucky enough to actually have known Michael or working with Michael, he was a cardiac pathologist at St. George's. He was really a wise man, a real example for all colleagues with an interest in clinical research. And we felt that he would have enjoyed most certainly having been part of a meeting of this sort, of this quality. So we have instituted this lecture, this memorial lecture, as a feature of all our meetings. And this year we have asked Professor Thomas Luscher to actually deliver the Michael Davis Memorial lecture. Thomas is a professor and chairman of cardiology at the University Hospital in Zurich. And he's got also quite a lot of administrative responsibilities and is running the department as head of cardiology, and is head of the cardiovascular research of the Institute of Physiology at the University of Zurich in Switzerland. Of course, he's the editor-in-chief of the European Heart Journal, and under his leadership, the journal has really achieved incredibly high standards, and we really are quite happy with that. Professor Luscher's research areas are basically on endothelial dysfunction, endothelium-derived mediators, which actually regulate vascular tone and affect platelet function. And one of the characteristics of his research is really translational in origin, and he and his group, of course, have made a substantial contribution to our understanding of vascular physiology and pathophysiology. He has published extensively, authoring over 500 original research articles and review papers, and is one of the editors of the ESC textbook of cardiovascular medicine. So it is a great pleasure for me to welcome Tom to St. George's, to London, and we'll be really delighted to hear what you can tell us in relation as to whether HDL cholesterol is still a target for therapy. Tom.
Thank you very much, Juan Carlos. It's a real pleasure and honor to give this lecture. And I obviously, as many in cardiovascular medicine, admire Michael Davis because he really taught us how atherosclerosis becomes really a dangerous disease, and the concept of plaque rupture stems from him, and I will come back to that during my talk. These are my conflicts, and I'd like to address a few issues: where we come from, what have we learned, and what is established, are there new targets, is HDL still a promise, and what do we look forward to? Where do we come from? This is also a bit of a historical lecture, so I would like to start with the first patient that unfortunately did not have the benefits we have today, and this is him.
Of the United States.
Good evening, my fellow Americans.
This is Eisenhower in 1955, shortly before he succumbed to a myocardial infarction. And in fact, this was in September, when Ike's heart attack began while playing golf at Cherry Hills Country Club on September 23, 1955, when he complained of what he thought he was indigestion. As all presidents, he had, of course, a physician who wasn't the best of his discipline, I guess. The president's personal physician, Dr. Howard Snyder, misdiagnosed the attack as a gastrointestinal problem and waited 10 hours before sending Eisenhower to the hospital. I say usually when I read this today, Dr. Snyder would be sent to jail, because we have changed things so considerably. With Franz Messerli, a compatriot and friend, we wrote this story in the New England Journal, and you can see here that Dr. Snyder then eventually gave him amyl of nitrate, the first substance in cardiovascular medicine to sniff, and sequentially injected papaverine, morphine, Morphine is probably even older. The president fell into deep sleep, not to awaken until 11 a.m. next day. His chest pain persisted, however. An electrocardiograph was brought from Fitzsimon's Army Hospital, so they didn't have an ECG. It recorded an anterolateral acute myocardial infarction, and the president was hospitalized eventually. More than 24 hours had elapsed since the onset of these first symptoms of myocardial ischemia. So these were really different times. And here are the heroes of the time. This is Dr. Howard Snyder, who was well trained in prevention. And this is the Braunwald of the day, Dr. Dudley White, who made his fame with the Wolff-Parkinson-White syndrome. And this guy, of course, himself was a smoker, as many GIs and generals in the Second World War. So what did they know more than 50 years ago on diagnosis, therapy, rehabilitation, and prevention? Actually, very little. Diagnosis was clinical examination, ECG. Only nitrates were standard the test of time, maybe morphine as well, of course. No defibrillation or revascularization was available. The rehabilitation was bed rest and wheelchair. You see him here with Churchill after his infarction. Prevention, there was nothing, but Framingham started to yield results. So what have we learned since? Well, the question is, why does a myocardial infarction really occur? And I think Michael Davis contributed enormously to it, although we haven't understood it completely yet. There's a genetic disposition for sure. There are risk factors we learned. There's aging, environmental factors, triggers of acute events, and unknown influences. The first man that really made this area blossom was Rudolf Virchow, a professor at Charité and politician, by the way, social politician in Berlin, who coined the term that atherosclerosis is a chronic inflammation induced by cholesterol. So he could have written all the papers of the last 10 years, 100 years ago. Then, of course, came a Russian physician, Anichkov, who got the Stalin Prize, not the Nobel Prize, although he truly deserves it. He worked with rabbits, he fed them with high cholesterol, and published eventually, a long time after his initial description in Russian, this book chapter summarizing his work, showing that high fat induces cholesterol dispositions in the aorta of the rabbit. And of course, to prove this in humans, that cholesterol is important, Framingham was started after the war and eventually led to our current knowledge that cholesterol is associated with mortality. And most importantly for our meeting today, that HDL cholesterol, strangely enough, had an inverse relation to the risk of coronary events compared to total cholesterol. And we'll come back, of course, to that. Now, this is Michael Davis, and he sort of in his brain looked at this lifelong development of a plaque with cholesterol depositions, with inflammatory cells, with a fibrous cap that at some point ruptures. And of course, the blood thinks that there is a hole here and tries to fix it, and by this occludes the artery. Now, what is established? Today, of course, the European Society of Cardiology, I'm a board member of it, and therefore I want to promote this, although there may be even more refined scorecards. Things today that age is sex, smoking status, blood pressure, and total cholesterol over HDL cholesterol ratio is the thing to use for your risk score to calculate the 10-year risk of fatal cardiovascular disease in populations at low cardiovascular disease risk. This is Switzerland. It may be different in the north and in England. But in principle, it's the same thing. So HDL is in the scorecard, and we can calculate risks of different subjects. I have two patients again from the same area. The first one is a high-risk patient, has a risk of 28% to die of an acute coronary syndrome within the next 10 years. He was a smoker of cigars, loved women, jogged only in front of cameras, had a lot of stress, a little bit of overweight, and the genetic disposition, and that's Bill Clinton. Now, there's another example of one that has only a 4% risk. He was also hardworking, a bit more ideological, I would say, than Billy. Trained every morning with his foreign minister, and had a very low risk, low CRP, low blood pressure, anything low you want, and that's George Bush. In the old days, I used to say, good for George Bush, bad for the rest of the world. I don't have the time to go into Obama. His risk is only 2.8%, although he's a smoker, but of course he's much younger. So we can treat this, of course, with statins. I will not repeat this because it has been extensively discussed today. The question is, what new targets do we have? We already heard about the mipamersin and about the PCSK9 inhibitors. You know that PCSK9 actually degrades the LDL receptor as well as the LDL, so the number of LDL receptors on the liver is decreasing, and maybe that's a protective mechanism, as we heard, and we will see whether when we inhibit it with a monoclonal antibody to actually recycle the LDL receptor to get a lot of receptor expression on the liver surface, whether this is going to be safe in the long term for this organ. But its effects on cholesterol obviously are impressive. This is just one of the most recent papers on this monoclonal antibody that has to be injected twice monthly or monthly, subcutaneously. It can also be applied intravenously. And you can see that there is an enormous decrease in LDL receptor, in LDL levels under these conditions that is dose dependent. Of course, we will see in the future whether that low LDL levels are still requiring additional treatment remedies as we discussed today. Now, of course, coming back to HDL, this also has been shown by Phil Barter, his analysis that shows that in the quintiles of HDL, the 5-year mortality still seems to have a U-shaped curve, whereby patients with low HDL, even on statin therapy, still have an elevated 5-year risk of a major cardiovascular event. And this was suggested to many that HDL is the next target in cardiovascular medicine as we look at other risk factors. And as you know, even and I mentioned this, the Framingham study initially showed that in fact there is an inverse relation between HDL and cardiovascular risk. So is HDL a target? Does it hold, or did it hold its promise? Let's look at a few aspects there. Well, first of all, 10 years ago with Lucas Speaker, we have infused reconstituted HDL, that's basically ApoA1 with phospholipids, a little bit of vitamin E, in patients with hypercholesteremia. And what you see here, this is the classic Four-Scott experiment where we have 4 on blood flow and acetylcholine, increasing dosages of acetylcholine infused intraarterially. And you can see that obviously in normal cholesteremic subjects, we have a very a marked increase in blood flow, about a 12-fold increase. So this is a real potent vasodilator. While if you have hypercholesteremia and you still don't have any major cardiovascular event, your endothelial function is reduced by about 50%. This may suffice to live, but it shows that early on changes in the vessel wall occur. Now, amazingly, if you now treat hypercholesteremics with reconstituted HDL to reach values from 1,2 up to 2.1 millimoles per liter, we can normalize endothelial function within 4 hours. I did not believe this initially, but it really seems to show that there is sort of a metabolic action of HDL and that these changes in the vessel wall occur rather rapidly under these conditions, at least in the early phase of the disease process. The reviewers in Circulation then asked us to show that this is actually also occurring with a receptor-independent stimulus, and we used flow-mediated vasodilation. that was developed by John Deanfield here in London. And you can see this in hypercholesteremics. There is about a 3% increase in brachial artery diameter. And after HDL, there's a substantially increase to near normal levels. So HDL seems to, at least this is sort of a pre-beta HDL, seems to actually have very protective effects in the cardiovascular system in humans in vivo. And this is particularly noticeable in hypercholesteremics. And I will show you that this also can be shown in vitro. Now, there's another piece of evidence in the Garda Lake area. There is a little village, Limone del Garda, where people apparently live up to their 100 years. And it was shown that ApoA1 Milano has a real protective action, although these subjects have low HDL levels when measured conventionally in a clinical chemistry lab. And Steve Nissen and his team has used this. This was eventually developed by several companies, bought by Pfizer, is now with the Medicines company. And the recombinant ApoA Milano was injected chronically in patients with coronary atherosclerosis. An intravascular ultrasound was used as an endpoint. You see here a coronary IVUS picture. Is the IVUS catheter here and the coronary plaque here. And they looked at lumen area, the EEM area, the atheroma area, and looked at the change over time. And they found in a significant improvement over several months that was, however, not dose dependent, which is a bit surprising and makes us a bit skeptical whether this is a true biological effect. Nevertheless, this again stimulated the interest in HDL-based therapies during the publication of this work in JAMA in 2003. What are the proposed anti-atherogenic effects of HDL? Well, HDL stimulates endothelial nitric oxide production. That has been shown in human aortic endothelial cells by many. This seems pretty established. It has anti-inflammatory effects. I will show that in more detail. It has effects on endothelial regeneration after injury. It has antithrombotic effects. In fact, we showed that normal HDL suppresses tissue factor expression, and it has antioxidant effects. Normally, and this is from an editorial to our paper in JCI in 2011, published by Christian Bessler and Ulf Lampmesser, together with members of our entire team, the normal HDL particle has an enzyme called PON1, pyranoxidase 1, that is antioxidant and will reduce the MDA levels within the particle. This ApoA1 can bind to SRB1 and through a cascade of kinases can activate eNOS at the serine 1177 site, which then leads to an increased nitric oxide production, reduced monocyte adhesion, endothelial repair, vasodilation, antiplatelet effects, all the good things that we expect. And indeed, this can be shown when we look at nitric oxide production from human aortic endothelial cells as measured by ESR spectroscopy. You can see that there is quite a marked increase in nitric oxide release upon the addition of healthy HDL from normal subjects without risk factors on human aortic endothelial cells and culture. When we obtain the same HDL from coronary patients or patients with acute coronary syndrome, we can actually see some sort of suppression that seems to be a bit more pronounced in ACS patients, although overall it wasn't significant. Now you can argue this may be a dose phenomenon, and so we did the whole experiments at different dosages with 25 micrograms, 50 micrograms, and 100 micrograms per ml of HDL, added again to aortic endothelial cells in culture, and you can see dose-dependent increase in nitric oxide release from these cells when normal HDL is used, again demonstrating or confirming the protective role of this lipoprotein particle in the cardiovascular system. However, in patients with coronary disease or ACS, this effect is completely lost and is less dose dependent. There is also an anti-inflammatory effect on endothelial cells of HDL in patients, in healthy subjects. And you can see here that if we stimulate VCAM expression with TNF-alpha, then the actual expression levels of VCAM are much lower with HDL, that would be 100%, or much lower if HDL is added. So you can suppress VCAM expression by about 40%, an effect that is totally lost if HDL is obtained from stable coronary disease or ACS patients, respectively. Furthermore, when you look at not actually the adhesion molecule expression, but rather the adhesion of monocytes on the endothelial layer, you can see again that there's a marked suppression by healthy HDL, that again an effect is lost in patients with coronary disease. So the anti-inflammatory effects seem to be lost once you get the disease. So your HDL has really changed its biological functions. It goes further. There is also an anti-apoptotic effect of HDL which goes through the caspase pathway and annexin 5. You can see that the caspase activity is suppressed by healthy HDL, but not by coronary artery disease HDL, and this can also be demonstrated for annexin 5. You can see here that's the expression, and then with healthy HDL you can suppress it, and this is lost if the HDL is obtained from a patient with coronary artery disease. Furthermore, endothelial regeneration or repair is an important mechanism in the cardiovascular system. The endothelial cells are continuously exchanged because of the shear forces, because of injuries or whatever, and this can be measured in the carotid artery of the nude mouse. In the carotid artery of the nude mouse, we can perform an electrical injury and denude the artery completely of endothelial cells, which is here stained blue. After a while, of course, there is endothelial regeneration, and this is facilitated with a healthy HDL, and again lost with HDL obtained from patients with coronary artery disease. And this is again shown as a summary in percent of the re-endothelialized area. You can see that with PBS there is about 15% re-endothelialized. With HDL from healthy it's more, and this is reduced in those mice that receive the coronary artery disease HDL, and the nude mice are obviously used to avoid any immune reactions. Steinberg has proposed as the first researcher in this field that oxidized phospholipids and oxidized lipoproteins may play an important role in the development of atherosclerosis and may be the major drivers of the inflammatory response that occurs during the development of the process. And so we looked at changes of HDL under these conditions. Now, one of the important enzymes that may oxidize lipoproteins is MPO, myeloperoxidase. That is an enzyme of white blood cells that creates free radicals that can change both HDL and LDL. Oxidized LDL is known since Steinberg's work as a major driver of inflammation, working through macrophages, through scavenger receptors, but also through scavenger receptors on endothelial cells like the LOX1 receptor. Oxidized HDL has not been studied in detail so far. What we first observed with Christian Bessler is the endothelial nitric oxide production here with a healthy HDL as a control experiment, and then MPO-derived oxidants were produced, and you can see that the properties of healthy HDL to stimulate nitric oxide production decline as it is oxidized by radicals generated from MPO. So it appears that this is important, and so there is always a protective system in nature, and so it is under these conditions. Peroxidase or PON1 is an enzyme that protects the lipoproteins, in particular HDL, from oxidation, and therefore we measured, of course, the activity and the levels of this enzyme within the HDL particle. And here are the results. You can see peroxidase 1 activity and peroxidase 1 content. And you see here that there is a marked reduction in peroxidase activity in patients with coronary disease and ACS. Stan Hazen from the Cleveland Clinic, with whom we are in a LEDUC network, actually showed that peroxidase is predictive of major cardiac events in the future if measured at baseline in subjects with coronary atherosclerosis. Notably, peroxidase content increased. Maybe this is a compensatory mechanism, but importantly, the activity of the enzyme was decreased. Now, of course, then the reviewers asked all kinds of questions. So we tried to inhibit PON1 is a calcium-dependent enzyme. So if you add EDTA while preparing the HDL, you can inhibit its activity, and indeed then also HDL loses completely its NO stimulating properties. And in addition, we did another experiment in response to the reviewers where we actually studied HDL from wild-type mice and PON1 knockout mice that do not have this enzyme. And you can see that this HDL is completely devoid of properties that are able to stimulate nitric oxide production from human aortic endothelial cells. However, if you then do the reverse experiment where you use recombinant PON1 and add it to the HDL of patients with coronary artery disease, you can rescue the nitric oxide stimulating properties, and this also can be done in mouse HDL obtained from mice that are knockout mice for PON1. If you then add reconstituted or recombinant, PON1, you can again rescue the NO producing effect. So PON1 seems to be extremely crucial in this context to maintain the biological properties of HDL under conditions of oxidative stress as it occurs in the organism, even under physiological conditions. There's an important enzyme that's activated under these conditions, and this has been shown by many. Also, Francesco Cosentino in our group in diabetes, and this is protein kinase beta 2. And it is of interest that if you inhibit this enzyme with different compounds produced by Novartis or Eli Lilly, that you can at least partially rescue the loss of nitric oxide stimulating properties in HDL from coronary artery disease patients. So how can we put all these data together? Now, the editorialists in JCI drew a really nice picture, and you can see, if you recall the previous picture, that this has now changed considerably. If PON1 activity is decreased, there will be more MDA, more modification of HDL particles, and then the HDL particle does not only bind to SRB1, but rather to the LOX1 receptor, which is a scavenger receptor mainly expressed in human aortic endothelial cells and other endothelial cells, and partially so also in macrophages. And this is linked closely to the activation of this protein kinase beta 2, which inhibits ACT. Now, ACT is a crucial kinase that phosphorylates the activation site of eNOS at S1177, while protein kinase beta 2 can phosphorylate eNOS at the inhibitory site, threonine 495. So under these conditions, we would have more adhesion molecule expression, more monocyte adhesion, less vasodilation, less endothelial repair, more apoptosis, so the whole the scale of events that I described a moment ago. In addition, we recently, with Emiliano Rivanto, working with Ulf Lampmesser's group in our department, and Rudi Abischer at the ETH, we looked at proteomics of HDL in patients with coronary artery disease. And you can see here, these are proteins that are enriched in HDL of coronary artery disease patients as compared to healthy subjects. So this is a difference. And here it's the other way around. These are proteins that are less expressed in the coronary artery disease patients, HDL, than compared to healthy control. So the HDL is sort of a shuttle for proteins and may reflect what's in the plasma. We don't know for sure, but there is a clear difference. And we have looked mainly at cholesterol and lipoprotein C3, but there are many others that can be studied, but there we would need really an army of postdocs to report on each of any single of these altered proteins. But what the main result shows is that the proteins contained in HDL change as we get the disease, and this may change its biological properties. Indeed, when we see this, we can say that in HDL of patients with coronary artery disease, there's more ApoC3, less cholesterol, and in the healthy one, it's the other way around. Here, through PI3 kinase, ACT is activated, and this is anti-apoptotic, and maybe also positive for eNOS. On the other hand, if there is ApoC3 dominant, then through another pathway, caspase is actually stimulated, more endothelial apoptosis, more vascular disease, and eventually more events. So what drugs do we have to treat HDL? Well, we have statins. They don't do much, a little bit. Fibrates are not very active. Nicotinic acid can actually increase HDL considerably, though depending on the dose that's used. Bile acid sequestrants don't do much, and they're not used in Europe commonly. The PPAR gamma agonists are not very effective either. The cannabinoid-1 antagonists also had some effect, but rimonabant was withdrawn from the market because of suicidal ideation and a few suicides. The CETP inhibitors obviously can increase HDL to 20, 50, or even more, as we will see in a second. So the first trial that I will discuss in the last minutes of my talk is the AIM-HIGH trial, where niacin was used to raise HDL on top of a statin. And this is the outcome after 4.5 years. Initially, it started with about 3,700 patients. It ended up with around 900. And you can see there was no effect whatsoever. This was certainly disappointing, particularly in the US, where this drug is commonly used. Now, what are the problems with the AIM-HIGH trial? First of all, is it underpowered? You know, the numbers we have here, we had the same situation with ACE inhibitors. QUIET with 2,000 patients was negative, neutral, and then HOPE with about 5 times as many patients was highly positive and changed our practice. The statin dose was not comparable in the two groups. To achieve and to address the HDL hypothesis, they wanted to achieve the same levels of LDL reduction. So those who had niacin had less statin dose, and so that may be a major bias. Third, as I showed you just a moment ago, it may well be that the HDL is dysfunctional, and as you increase the HDL in this patients, you just increase bad HDL, and you lower a bit of LDL, and then you end up with a neutral result. Or maybe the whole concept is not right. So they will test this in a huge trial, the HBS2 Thrive, with nicotinic acid and laroprovant, as mentioned by previous speakers. Now, the CETP inhibitors are, of course, the newest hope, whereby the whole cascade of HDL production is inhibited at that stage here. That's a slide I owe to Arnold from Eckartstein, which clearly shows the HDL metabolism. Now, the Illuminate trial is an interesting one. As you know, the HDL was increased really dramatically, and you would have thought you live forever, particularly since LDL was in addition reduced by around 20%. But contrary to our expectations, the actual major cardiovascular event rate was significantly higher in those receiving torcetrapib compared to those that received only a torvastatin alone, and this was a highly powered trial. So clearly this drug had effects that were beyond HDL, and we did look at this with bronchosimage and published this in the European Heart Journal lately. Aldosterone is up if you feed animals that have no CETP, like rodents. With torcetrapib, you get increases in aldosterone, in blood pressure, nitric oxide is reduced, endothelin is increased. And so this is a complete disbalance of vascular hemostasis and blood pressure regulation that may explain the results. It cannot be only blood pressure, because it wasn't just stroke with torcetrapib. It was all kinds of cardiovascular events, suggesting that vascular dysfunction was even more important. Now the question then was, is this a drug effect or is it a molecule effect? Are the untoward effects of torcetrapib a class effect or related to this particular molecule? And now we know that small changes in molecules may make a huge difference. I'll just show you one example. This is a steroid. Some of you may recognize that. And this is another steroid. And the change is has a change just here, but the phenotype is dramatically different. This is testosterone, and this is estrogen. So maybe that applies also for CETP inhibitors. And so we have now 4 of them, and in addition, 4 of them in total right now that have been discussed just a minute ago. We studied mainly dalcetrapib, and I will show you a few data on that. We did the dull vessel trial in 450 patients, where we did flow-mediated vasodilation as an index of the vascular effects of the raising HDL therapy, with 1 minute baseline, 5-minute cuff inflated, and post-hyperemia. And Juan Carlos Koski was part of this team, as was John Dienfield, who participated in this morning's meeting. And then, of course, you measure the vasodilation as an index of vascular health, if you want. So we did study about 476 patients, randomized to 800 milligrams dalcetrapib or placebo over a 36-week period, and we also measured ABPM, or long-term blood pressure. Now, as expected, HDL went up by about 30%. LDL didn't change at all. These are results that were completely reproduced in the DOL outcome trial that I will show you in a second. And ApoA1, of course, went up, while ApoB100 did not. Now, the baseline FMD exhibited no significant change with dalcetrapib over 36 weeks. As you can see here, is a pretty flat line. And when I presented that to the board of Roche, they asked me, didn't you expect a positive effect? And I said yes. But nevertheless, they went on to fund a huge program with many trials that eventually all did not lead to a new remedy. Now, blood pressure was a big issue after torcetrapib. We did not find any change at all in our population of 476 patients randomized to placebo or dalcetrapib. In the DOL outcome trial, which was bigger, there was a 0.6 millimeter systolic blood pressure increase, which I believe may only have a minor effect on the results we'll look at in a minute. So this is then, of course, the next trial. Initially, they wanted to use DOL vessel as a safety trial after torcetrapib, but they were happy that it wasn't negative, no toxicity, as they said in the board meeting, and were very excited, although we, as investigators, were all very disappointed that there was no effect on endothelial function, because ACE inhibitors, statins, all the other protective drugs show a marked improvement. And also HDL, as I showed you in a minute. So this is the large trial in thousands of patients. And here are the characteristics. And I think it's interesting to look at it. It's about close to 16,000 patients. They were randomized 61 days after an acute coronary syndrome. So it was not in the acute phase, but in the subacute phase. They were all treated with statins, 98 and 97%. They had LDL cholesterol levels that were really in the target range, below 100 millimoles per liter, and the milligrams per deciliter, with the American concentrations. HDL was in the range of 40. And what they found is that after 3 years, there was no sign of any effect. This is the overall picture, and this is just the enlarged picture. You can see that the event rate was close to 10% after 3 years. This is much lower than in other clinical trials, such as the RELY trial with ticagrelor, where the event rate was much higher, was 10% in the first year, but there was no indication of any effect of dalcetrapib under these conditions. Now the question is, what is the reason? Well, I'll show you just one slide, and this shows the annualized event rate according to HDL. These are the different levels of HDL in the placebo and dalcetrapib group, and you can see there was no predictive effect any longer of HDL under these conditions. There was then, in addition, they looked at the change in HDL and the event rate, and here you may see a little bit of it, but it wasn't significant. So it seems that under these conditions there's no protective effect, even if you increase it tremendously. We have now data of HDL biological properties of patients that are treated with dalcetrapib and torcetrapib, but I cannot show them in detail yet because we're submitting the manuscript in the future. So just to finish up, anacetrapib and now also everacetrapib are further developed. Anacetrapib is of course different than dalcetrapib. It cannot test the HDL hypothesis because it has such a marked effect on LDL as it has on HDL. Nevertheless, I think this will be an important basis for the REVEAL trial that's run out of Oxford and Boston, and we will have to wait and see what will happen then. So is HDL still a therapeutic target? HDL-based therapy should not only consider plasma levels, but improvements in its biological properties. So far, none of the available drugs worked. We will see whether the currently developed CETP inhibitors will change the picture. So we have to still do research, and as Albert Einstein said, the important thing is not to stop questioning. Thank you very much for your attention.